All right, good afternoon, everyone. My name's Enrique Morato, and today we're going to be going over diabetes. I'm going to break it down in parts. For the next 10-15 minutes, I'm going to go over how the normal function of the pancreas and our metabolism should be. And then we're going to get into diabetes type 1, diabetes 2. I'll touch up on metabolic syndrome, how physiologically the body responds to diabetes in a prolonged, uncontrolled diabetic, and the symptoms, clinical manifestations, how we can diagnose this, and how we could go about treating diabetes. So starting with the first section, our regular metabolism. Normally, when we eat something, it starts to get partially digested, and since this isn't a digestive lecture, we'll just go real quick through the digestive process. Some proteins and carbohydrates begin to get broken down in the mouth and down in the stomach. It turns into chyme, and then it is through peristalsis thrown into the duodenum. In the duodenum, our fats get emulsified right here in orange by our bile. Our bile goes ahead and emulsifies our fats. They turn then into chylomicrons, and these chylomicrons are big molecules, so they're not absorbed easily by our portal circulation down here. So what happens is that they get absorbed by these lymphatics. So chylomicrons that come from fats, whether it's cholesterol or any other type of fat that you have in your diet, once they're emulsified by bile, they're absorbed through the digestive system, through the membranes of through the lumen of our duodenum and jejunum, and they're then absorbed into the lymphatics. That lymphatics works its way up into the thoracic cavity, where it joins the superior vena cava and enters our heart and enters the rest of our circulation. And that's how fatty acids are distributed throughout our bodies, whether it be cholesterol or whether it be triglycerides. Glucose is, however, broken down in the duodenum to such small particles that they can easily be absorbed through our portal circulation. So here you have some glucose metabolism in black. Glucose is broken down and it is readily absorbed through the capillary, the venous side of our capillaries, into our venous circulation, into our hepatic circulation. This is the superior mesenteric vein, which joins the splenic vein over here and enters our liver. A lot of this glucose actually then leaves the hepatic circulation and enters into our systemic circulation. And some of it is stored in the liver, and eventually it makes its way to the pancreas. Once this circulation with glucose, rich in glucose, makes its way to the pancreas, it's going to have two effects. It's going to affect our alpha cells, which are responsible for the secretion and production of glucagon, and it's going to stimulate our beta cells, which are the most abundant cells in our pancreas. Now, the beta cells are responsible for the production of insulin. Okay, this is a quite simple diagram. We're not going into molecular biology here, but this is an example of a glucose molecule, and it readily enters a beta cell. So this beta cell right here is the square that I actually drew over here. When there's glucose present, this glucose enters the beta cell without the need of insulin. Okay, no insulin is needed for this cell to absorb this glucose. The more glucose that enters, the more it triggers this cell to produce insulin. So that's the function of a beta cell. It is stimulated by glucose to produce insulin. Okay. The alpha cells have the opposite response. The alpha cells, in the presence of glucose, actually inhibit the production of glucagon. Okay, glucagon does provoke the liver to produce and break down fatty acids into glucose. Okay, so when we have a low amount of glucose in our circulation, therefore we have a low amount of glucose stimulating the cells of the pancreas, we have the inhibition of glucagon is down-regulated. So you have less inhibition of the alpha cells, meaning that the alpha cells are going to more readily produce glucagon. Okay, when we have high amounts of glucose in our system, right? You just finished eating a meal, you're going to have more glucose circulating throughout the entire body. Hence, you'll have it circulating throughout the pancreas as well. In that case, it's going to suppress glucagon because you don't need any glucose. You just ate carbohydrate-rich food, let's say. And the beta cells will be stimulated to produce insulin. Now, in the presence of fasting, you're still going to have some glucose in your circulation. You could fast for 2 or 3 days, and you're still going to have glucose in your circulation because these alpha cells should be producing glucagon to maintain your blood sugar within normal range, maybe 60 to 80 if you've been fasting for several days, okay? And that's a whole other subject that we could go into later in the digestive and metabolism. So this is the way that the pancreas works. This is the way that our beta cells work and our alpha cells work. In diabetes, let's talk about diabetes 1 first. It's most commonly seen in younger children. It's sometimes genetic, and the majority of the medical personnel believe that it is most of the causes are an autoimmune cause. Okay, you could have diseases, right? Viral infections or bacterial infections when you're young that could actually basically destroy and provoke an autoimmune response against your beta cells. Okay, now it's not just the beta cells, right? You have your entire pancreas attacked by certain infections and by your immune system sometimes. The thing is that the beta cells outnumber any other cell in the pancreas. So since there's more beta cells, they're going to be more susceptible. There's more surface beta cells than there are alpha cells or delta cells or any other cells in the pancreas. So they're the ones that become mostly affected. In diabetes type 1, you could have no production of insulin because most of your beta cells are destroyed. You can have very minimal production of insulin, okay? But the clinical presentation is that you don't have adequate insulin or any insulin at all to stimulate any other cell in the body for it to absorb glucose. So this is how diabetes type 1 is, as you can imagine, is an insulin-dependent individual. So if you do have diabetes type 1, you will need insulin. It's a given. You don't have it, so you're going to need it. In diabetes type 2, what happens is that our cells throughout our entire body become resistant to insulin because you're always carving up. Let's say you're always eating a sugar-rich foods or carbohydrate-rich foods. Okay, you're constantly increasing your blood glucose in the blood. All right, you're constantly increasing glucose in your blood. So what happens is that you're constantly stimulating beta cells to produce insulin, and your cells systemically always respond to this. After years and years of abuse, the receptors tend to become more resistant to insulin activation. Okay, so what happens is that your receptors actually start to ignore insulin, and there you have to be very careful that you don't eat a carbohydrate-rich food, and you have to have a tight monitoring in your diet because the receptors that you have are not responding, so they're not absorbing this glucose. So what happens is that if you keep on eating the way you do, which got you there in the first place, you're going to have an increased amount of sugar in your blood. And can you imagine this day after day after day for months, for years? This extra amount of glucose that's going to be circulating in your circulatory system is going to accumulate, and it's going to cause some damage. And we'll get into that in a little bit once we start talking about the systemic effects that diabetes has on us. So in diabetes 1, our beta cells are not functioning, so we're not producing insulin. In diabetes type 2, our beta cells are functioning and they are producing insulin, but our cells in our body, the receptors that are stimulated by insulin, they're ignoring insulin because they're tired of insulin constantly bothering them. They're tired of the oversaturation of insulin stimulating those receptors. Okay, so that's the importance of watching the amount of sugar and the amount of carb that you eat. That's why when you eat, you want to eat carbohydrate-rich, not carbohydrate-rich food, but you could eat carbs. They just got to be whole grains, whole grains, whole wheat, complex carbohydrates. Because complex carbohydrates take a little bit longer than simple carbs to get broken down into glucose. Okay? So you're going to have a larger molecule, and it's going to take a little bit longer. So you're digesting that little by little. You're squirting a little bit of glucose into the blood little by little, as opposed to eating simple carbs and simple sugars, which right away get absorbed. Because remember, the membrane right here and the capillaries right here love to easily absorb glucose, simple glucose. It's a very small molecule and it's easily taken into the blood. If you eat complex carbohydrates, they take a little bit longer to get broken down. So they don't entirely rush into the circulatory system at once. So in a nutshell, that's what diabetes type 1 and diabetes type 2 is. Diabetes type 2 is usually seen in individuals that are heavier set, especially if they have a long exposure to a bad diet, carbohydrate and sugar-rich food. And a diabetic 2 patient can become a diabetic 1. Okay? A diabetic 2 patient, if severe enough and doesn't take care of himself, can eventually burn out his beta cells. And his beta cells will then stop producing insulin, and you will see them turn into a diabetic type 1 patient, and they will become insulin dependent if they don't watch out what they eat. They don't take care of themselves when they're diagnosed.